Welcome to this Clinical Explainer, where we're going to break down a study that could genuinely change how you manage hypertension. The big idea here is a fundamental shift in strategy, moving away from a reactive cycle of measuring and reassessing and toward a proactive model where we can predict a drug's power and prescribe with confidence right from day one.
So, let's start with a question that really cuts to the core of our daily practice. We all do it, right? We start a medication, have the patient come back in a few weeks, and check their blood pressure to see if it worked. But what if that single follow-up reading, that number we rely on to guide our next step, is actually an incredibly unreliable, noisy piece of data?
And here's the other side of that coin. Imagine approaching hypertension with the same predictive power we have for high cholesterol. Think about it. We don't just guess what a statin will do. We prescribe a high, moderate, or low-intensity regimen because we know based on massive trials what kind of LDL reduction to expect. This study suggests we can finally bring that same evidence-based confidence to blood pressure management.
Now, this new paradigm isn't just a theory. It's grounded in a massive systematic review and meta-analysis published in the Lancet called Blood Pressure Lowering Efficacy of Antihypertensive Drugs and Their Combinations. And when I say massive, I mean it. They synthesized the data from an incredible 484 randomized, double-blind, placebo-controlled trials. As always, you'll find the links to the full bibliography in the description below.
Okay, so let's get into the core problem with the way we've been doing things. The authors frame this as a classic signal versus noise issue. The drug's real effect is the signal, but it's getting drowned out by a whole lot of noise.
And this quote from the paper just hits the nail on the head. A patient's own blood pressure naturally bounces around all the time. That's the intra-individual variability. What this study found is that this biological static, this noise, is so huge that it completely overwhelms the actual effect of the drug, which is the signal. It's like trying to hear a whisper during a hurricane. Chasing after a single blood pressure reading is just not an effective strategy.
This really lays out the paradigm shift perfectly. We're talking about moving away from the old way, that reactive loop of measuring, reassessing, tweaking the dose, and measuring again, all while fighting that statistical noise. Instead, we're moving to a new, proactive approach, where we use the evidence from huge clinical trials to predict a regimen's power and prescribe the right intensity from the very beginning.
So, if we're not supposed to be chasing individual numbers, what should we be focused on? Well, the study proposes a new framework, one that's going to feel very familiar if you prescribe statins. It's all about classifying treatments by their intensity.
And the framework itself is beautifully simple. The authors took all those antihypertensive regimens and sorted them into 3 tiers, based on their expected systolic blood pressure reduction from a standardized baseline. Low intensity gives you less than a 10 mm mercury drop. Moderate intensity is in the 10 to just under 20 range, and high intensity gets you a powerful reduction of 20 mm mercury or more.
All right, this next point is, for me, one of the most powerful practice-changing findings in the whole paper. The best way to think about it is with a metaphor. To make your car go a lot faster, you don't just pump more gas into one engine, you add a second engine. Let's look at the actual data, because it's pretty shocking. A standard dose of a single drug, a monotherapy, gets you on average an 8.7 mmHg reduction. Okay, so the logical next step is to double the dose, right? Well, look at this. That only gets you an additional 1.5 points. But if instead of doubling the dose, you add a second drug at a standard dose, you get a nearly 15 mmHg reduction. The difference is absolutely huge.
Let that sink in. Adding a second drug from a different class is roughly 4 times more effective at lowering blood pressure than simply doubling the doses of a single agent. This one fact alone should really change how we all approach treatment intensification. It's a game changer.
So this is all great information, but how do we actually put it into practice in a busy clinic? Well, this is the best part. The researchers didn't just publish the data. They synthesized all 484 of those trials into a powerful, practical tool we can all use.
They created an online efficacy calculator, and it's available for free right now at bpmodel.org. That's bpmodel.org. You can go there, plug in a patient's baseline blood pressure, and then play around with different drug combinations and doses to see the trial-based prediction of what kind of reduction you can expect.
Let's walk through a quick practical example from the paper. So, say a patient on lisinopril 10 milligrams alone. That's a low-intensity regimen. It's predicted to give you about a 7 mm HGG drop. But what if that patient needs a high-intensity effect? They need their pressure down by more than 20 points. Well, the path forward is crystal clear. You don't just max out the lisinopril. Instead, look at that bottom row. Combining lisinopril 20 with HCTZ and then adding amlodipine 5 milligrams, boom, You're at a predicted 22mm HGG reduction, squarely in high-intensity territory. You can strategically build the perfect regimen to match the patient's needs right from the start.
So let's tie all of this together into a new clinical workflow. How do you actually put this into practice tomorrow morning? It really just comes down to 3 key steps.
First, target intensity, not just numbers. If your patient needs a 25-point drop to get to goal, don't start them on a low-intensity monotherapy. Start with a high-intensity combination. Second, prioritize combination therapy. Remember, adding a new drug is far more powerful than just doubling a single dose. And third, to make it all work, use the calculator. Go to bpmodel.org and let the evidence guide your decision-making.
And if there is one single pearl to take away from all this, one phrase to share with your colleagues, it's this simple mnemonic: add, don't double. It perfectly sums up the core finding about the incredible power of combination therapy. So in summary, this huge body of evidence gives us a new way to think and act. It allows us to move away from the frustration of chasing those noisy, unreliable blood pressure readings. Instead, we can start our patients on regimens with a predictable, evidence-based efficacy. We can get them to goal faster and a whole lot more efficiently.
So here is the call to action. The very next time you're seeing a patient with hypertension, before you write that script, just pull up bpmodel.org, plug in the regimen you were thinking of prescribing, and see its predicted intensity. Use this incredible tool to start the right treatment right from the beginning.
You can find the disclaimer and the full bibliography in the description below. Thanks for joining this Clinical Explainer.